This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning we have a real treat with us. Dr. Guyton is with us, and he is literally a man who needs no introduction. All of you know Dr. Guyton, who is, in addition to be a spectacular surgeon, made numerous academic achievements and contributions to the field, and continues to be a leader in all aspects of cardiac surgery. And I think he's going to talk a little bit about an area that is just absolutely blossoming, and an area that is sort of the next frontier in structural heart, I guess was fair to say. And with that, we'll welcome Robert to tell us all about how to fix the mitral valve.
So I'm not sure it's blossoming. I think it's the next challenge, not the next frontier. It really is a tough area. So functional mitral regurgitation. Disclosures, I have research support from Edwards Life Sciences. This is a slide that Dr. Padala, who's our second speaker today, put together. There are three components of ischemic or functional mitral regurgitation: annular dilatation, flattening, but most important, the ventricular components, particularly after an infarct. The case presentation this morning, to begin with, was a 15-year-old young lady who presented to the Grady emergency room with a gunshot wound to the chest. She had hemorrhage, chest was open, the pericardium was packed. She was resuscitated on the ventilator for 3 days, recovered, but her echo showed severe regurgitation. Her cath showed occlusion of a large circumflex marginal and a lateral wall infarct, but no ischemic areas. Now she's 4 months after the gunshot wound, New York Heart Association Class 4. You can see she has a dilated ventricle, tethering of the valve, tenting of the valve, an infarct with a papillary muscle that's mostly scarred, in the posterior papillary muscle here, and severe regurgitation with a dilated annulus as well. So here we have a 15-year-old, can't walk more than about 100 feet without getting short of breath, can't go to school. Do we wait for the adhesions to mature? At 4 months, it's a hard time to go back in. Do we repair it? Do we replace it? If we replace it, use a biologic or a mechanical valve in a 15-year-old young lady. We know that if you have a myocardial infarction, this is data from the Mayo Clinic, that if you have regurgitation, your 5-year survival is very different than it is if you don't have regurgitation. Without regurgitation, the 5-year survival is 60%. With regurgitation, it's 38%. But importantly, the definition of with or without regurgitation is less regurgitation than we're accustomed to dealing with degenerative or primary regurgitation, in that this is an ERO greater than 20. Normally, with primary regurgitation, the ERO is greater than 40. This is the reason that the new guidelines define severe regurgitation in secondary MR as an ERO greater than 20. The severe regurgitation defined in primary mitral regurgitation is an ERO greater than 40. Also, a regurgitant volume of 60 is the definition for primary regurgitation, and 30 is the definition of severe MR for functional or secondary regurgitation. First question is there a survival benefit for repair in this young lady? It's been very hard to show that there is. From Michigan, an epidemiologist put together a series comparing Steve Bolling's 126 patients that had downsizing annuloplasty and compared them retrospectively to 419 surgical candidates who did not have regurgitation, and really showed no difference. Bolling contests these. He says that these were early in his experience, that he's doing better now, and indeed there is data that these patients stayed out of the hospital more and had a better quality of life if they were treated. But it's still a disputed topic. What predicts failure of downsizing annuloplasty, which is what we usually want to do for this? It's a fairly easy thing to do. There is good data from Europe, from the Netherlands, 100 consecutive patients with downsizing annuloplasty. The early mortality 8%, 5-year survival 71%. But the patients with the large ventricles were the ones that died. The patients with the smaller ventricles really survived pretty well. This is the differentiation in that series. The patients with ejection fractions less than 65 had about a 15% 5-year mortality. The patients with a end diastolic diameter greater than 65 had a 50% 5-year survival. So the thought is that if we've got a dilated cardiomyopathy with MR, it certainly would be best to get to them before the ventricle gets so dilated that we can't treat it. Can we do better with the annulus than just putting in a regular flexible downsized ring, which is what we often use, the physio ring? The answer is yes, we can use ischemic rings with septal lateral shortening. The best of these is probably the geoform ring, and you can see the extreme decrease in septal lateral shortening with the geoform ring. But Dr. Padala will tell you a little later on about the reason that just putting in a ring isn't sufficient in these patients. What have we done to go below the annulus into the ventricle? What we've done is take this papillary muscle and pull it toward the annulus, or pull the two papillary muscles together. Dr. Krohn developed a procedure in which he took the posterior papillary muscle, put a stitch in it, and pulled it up toward the annulus to decrease the tenting, because the regurgitation usually is most prominent in the posterior commissure. And he has results that show that in patients, 105 patients with ischemic regurgitation, 35 had repositioning. In the 35 that had repositioning, he had a 5-year survival of about 90%, which is pretty good in patients with MR, because we saw the Mayo Clinic series looking at about a 30% mortality. This is about a 15% mortality. The second procedure is a papillary muscle sling or papillary muscle approximation, which has been in use in Europe for a number of years. This is a group in Paris, 37 patients, 2 operative deaths, which is pretty good, 5%. The left ventricular end diastolic dimension was 70. These were big ventricles, and the end diastolic dimension decreased to 56 at 1 year. So by pulling the papillary muscles together, they got a revision of the left ventricular dilation. The ejection fraction increased from 30 to 49, so this is another possibility. The best series that we have is the ACORN trial, 193 patients assigned to mitral operation and 93 to mitral operation plus the core cap, which is the kind of hat, restrictive hat that goes on, which was the focus of the core cap trial. The restrictive cap didn't make a lot of difference, but these patients had remarkable results with undersized rings, and if the rings were not sufficient to get rid of the MR, 29 of them had replacements. These patients had dilated ventricles with an end diastolic dimension of 70, ejection fraction average of 24%, which means a lot of them were down less than 20%. The 30-day mortality was really great at 1.6%, and the 5-year mortality was 30%, again, better than you would expect with a ventricle at 70 millimeters. 29 patients had recurrent regurgitation, and 5 had a mitral reoperation. But this is a showing of the change in the ejection fraction in these patients over the 5-year period. This is an absolute reduction of 5%, improvement of 5% in the ejection fraction in the surviving patients. This is also the survival, showing a 30% mortality over the 5-year period in the ACORN trial. And this is the incidence of mitral valve repair or replacement, or 3 to 4 plus MR, showing that only 20% had either replacement or recurrence of 3 to 4 plus regurgitation. The other topic, considering this patient, do we repair her valve or replace it in severe regurgitation? We know that replacement compared to repair is easier, more predictable, and has durable relief of regurgitation. Replacement, however, has a 1% per year higher rate of stroke and endocarditis compared to repair. And when we're thinking about a 17-year-old young lady, that's a big issue for her. This is the randomized trial done by the CTS Net of this study. Only 250 patients randomized, but it was sufficient to show some difference. This is the patients that had repair versus replacement. Notably, there was recurrence of regurgitation at 1 year in 32% of the patients that had repair, compared to only 2.3% in the patients that had replacement. But we've got to remember this is a surgical definition of recurrence of regurgitation, which is 2+ or more. The MitraClip definition of recurrence of regurgitation is 3+ or more. If we use the MitraClip definition of recurrence of regurgitation, then the recurrence in this series was only 4% at 1 year. It's a huge difference in your mental thinking about it when you use a MitraClip definition versus the surgical definition between 2+ and 3+. So in summary, about repair versus replacement, you should repair the valve if the coaptation depth is less than 1 centimeter and the tenting area is greater than 2.5, or if the end diastolic diameter is less than 65. If these criteria aren't met, we should replace it, or in experienced hands, repair with a modified ring plus adjunctive intraventricular procedures. In intermediate or high-risk patients, that is the aged, the frail, it seems that we should repair it only if the repair is simple, predictable, and durable. Otherwise, we should replace the valve to prevent recurrence of regurgitation. So severe regurgitation in dilated cardiomyopathy, there's not much evidence that we prolong life, but the operation is useful for relief of symptoms, decreased hospitalization, and perhaps in a young person to remodel the ventricle, particularly a young person with symptoms. And no evidence right now of survival benefit. There's a persistent question, might there be a survival benefit with a less invasive elimination of functional regurgitation, not having to put the patient through the big operation and losing 5-8% of your patients with the operative procedure. So in this particular young lady, I took her to the operating room, spent 70 minutes trying to repair her valve. Dr. Padala did a computerized analysis of it using her CT scan, and he essentially told me that the ventricle was too big, too dilated, that the valve was pulled down too far, and I wasn't going to be able to do it. But still, I tried pulling the papillary muscle up. I tried pulling the papillary muscles together, used a downside ring. After 70 minutes, it was not going to be repairable, so I replaced her valve. She wanted a biologic valve, which can have a valve in the future so that she can have children, so that she can be normal. She's back. She was back at school in 2 months, able to participate, even doing some mild athletics. So symptomatically, she was dramatically improved, and we'll see how she does over time. So I want to talk about 2 patients quickly, and then we're going to turn it over to Dr. Padala to look at where we're going in the future and what he's looked at in the laboratory. This patient is a 59-year-old ex-Marine. He, with New York Heart Association class 3 to 4, he essentially had to stop doing all the athletic things that he had done before, was able to walk across the room, but that was about it. He had non-ischemic cardiomyopathy, paroxysmal atrial fibrillation, previous history of prostate cancer. His coronaries were essentially normal, ejection fraction 30%, good kidneys, good lungs, but he had an 8-centimeter left ventricle with an ejection fraction of 30%. This is his echo. He was evaluated for a transcatheter mitral valve in the early feasibility study, but you can see how really big his ventricle is. This is his echoes, showing severe regurgitation with 2 orifices. It was felt that if we used a MitraClip, we're going to need to use at least 2 in each of these orifices, and likely would leave him with some stenosis. I decided to operate on him, put in a bioprosthetic valve, but we brought his papillary muscles together, did a papillary muscle banding, and you can see the papillary muscle band here, pulling the 2 papillary muscles together in his postoperative situation. And here's another picture of the band with the papillary muscles being pulled together. This patient is now about 4 weeks post-op, still struggling with his heart failure management, as Andy well knows. And we think he's going to be better, but it's hard to know. But we did feel we needed to do something more in this 8-centimeter ventricle than just downsizing. His maximum oxygen consumption was 17. He really wasn't a candidate at this point for destination therapy, and we'll have to see. But this is what we're looking at as the different options in these patients. Final patient with functional regurgitation, 83-year-old male, class 4, hypertension, dyslipidemia, atrial fibrillation, myasthenia gravis, stable on Imuran and Mestinon. He had complex regurgitation with functional regurgitation, but also with a couple of ruptured cords as well. You can see torrential regurgitation. He was a candidate for the CardioQ valve. This is the CardioQ transcatheter valve, which can be put in either transeptally or transapically. It has a skirt. It's put in at the annulus and rises up mostly into the atrium. It does have a sealing skirt that helps decrease the regurgitation. Can be put in transeptally or transapically. Transapical is a little harder on the patient. We're moving aggressively towards transeptal placement. This is actually Mr. Wall's, this particular patient's implantation here at Emory. This is a balloon being passed along the guide wire. The guide wire goes in the femoral vein, loops in the left ventricle, comes out the femoral artery, and then this balloon is passed to make sure we don't have any chordal entrapment with the guide wire. This is the valve being positioned. The ventricular anchors have been deployed so that we capture the the leaflets of the valve. This is the echo. It's very echo intense. The echo imaging is critical and a major part of this to make sure we capture at least 11 out of the 12 anchors have to capture the leaflets. This is the valve now releasing the atrial anchors, which are on the top side, on the atrial side. The atrial anchors are released, and then when we're sure that everything's in good position, we release the valve. There's the valve released. And this is the ventriculogram after deployment. And you can see here how high the valve sits up in the left atrium. We have had difficulty with all the transcatheter valves across the country, all different types with clotting of leaflets, not just the CardioQ valve, but also the Fortis valve, the Tendyne valve. All the valves have had difficulty with clotting of leaflets, probably because the washing of the leaflets is unusual. These are also big valves, and only 1 or 2 leaflets need to open to let the blood flow in. If one leaflet is lazy, it will become more and more lazy and seems to clot off. So I think I'm going to stop there, and the more exciting stuff I think is what Dr. Padala has to present. So we'll turn this over to him.
Thank you.
Oops. Put it back in.
Thanks. Thank you, Dr. Guyton and Dr. Taylor, for the opportunity to present some of our work that we are conducting in the Cardiothoracic Surgical Laboratory in the Division of Cardiac Surgery. So today my second half of this talk is going to focus on 3 main things that we are pursuing in the laboratory. The first thing is, what are the failure mechanisms of mitral annuloplasty in functional mitral regurgitation, and how can we improve outcomes? The second thing is, what could be the future of transcatheter approaches for functional mitral repair, and I'll be introducing to you a concept that we have developed in the laboratory. And finally, a little bit of our recent work on what is the relevance of functional mitral repair in improving cardiac function. To begin with the first part, which is failure mechanisms of annuloplasty, these are the 3 lab members who have helped me. So undersizing annuloplasty, as Dr. Guyton has shown, is the current repair of choice, but the outcomes are not optimal. So to understand the failure of annuloplasty, we need to get back to the anatomy of the valve. So if you look at the anatomy of the valve, even though on echocardiography the mitral valve looks like just two leaflets that are deforming and coapting, there is a lot more complexity involved in it. And the complexity actually does not emerge from the atrial side but from the ventricular side. If you look at this photograph from the ventricular side, we can see that the anterior leaflet is divided into two parts. The top part, where there are no caudal insertions, you have a very nice smooth and collagenous layer. And the bottom part, which is the rough zone, as we all know, where there are a lot of caudal insertions. So when the ventricle dilates in functional mitral regurgitation, the focus is less on here and more on here. And if you actually feel the mitral valve in pigs or humans, you can actually feel that the tissue in this rough zone is much more stiffer, and in the smooth zone is a lot more compliant. So most of the closure of the mitral valve in systole occurs because of the deformation of only this region, and functional mitral regurgitation occurs because this region does not deform. And I want to present to you why that occurs. So if you look at the native anatomy of the mitral valve, it has a very complex structure. We have two leaflets which are almost irregular and do not match with each other. However, when you bring them together onto a D-shaped annulus, you have very nice leaflet coaptation with a region of coaptation starting from one commissure to the other on both of these leaflets. If you look at the caudal insertions, as I just mentioned, there are several chordae that insert from one papillary muscle and continue towards the other papillary muscle through the mitral valve, mainly through the edge of the leaflet but not towards the mitral annulus. Similarly, we can see this pattern in the posterior leaflet as well. So when I began my laboratory, I started studying how do these different control mechanisms actually control the valve, and in a normal heart, how do they fail in functional mitral regurgitation, and how do they even fail when you have undersizing annuloplasty, and how does that impact closure? So if you look at the normal closure of the mitral valve, and this mechanism has been defined in 1960s by Robert Frater in his thesis to the Mayo Clinic, where he showed that in dog mitral valves, going from diastole to systole, most of the deformation occurs in the edge. The edges of the two leaflets parallelize with each other, and that parallelization enables a good overlap between both of them, resulting in coaptation. And as I mentioned, that occurs for the same amount of transvalvular pressure. It is the edge which deforms more compared to the rest of the leaflet, and that is because this part of the leaflet is a lot more compliant. So what happens in functional mitral regurgitation? Firstly, the papillary muscles move away from each other and also from the mitral annular plane. So there is a lot of tethering force that is imposed on this compliant region. So imagine this to be a sail. If you have tethering through the strut cords and the marginal cords, everything that is in between becomes stiffer. So it cannot deform as much. And that results in loss of coaptation, resulting in regurgitation, as I show in the schematic. This is a pig mitral valve where I show the same phenomena that I just described. This is a normal valve. This is the anterior leaflet. You can see that the rough zone is very compliant. It can deform really well. When you have apical tethering only, you can see that only the smooth zone is stiffened but not the rough zone. Whereas when you have apical posterior lateral dilatation, which is typically what you see with left ventricular dilatation, you see that the marginal chordae are now tethered and the edge of the leaflet becomes stiffened. So if you look at an en-face view, that is exactly what is happening. In a normal valve, you have a very slackened leaflet edge. So this is the anterior leaflet, this is the posterior leaflet looking from the ventricular side. And when you have a tethered valve, you have these edges which are significantly tethered and cannot deform. So what we hypothesized was that when you do undersizing annuloplasty, definitely you are pulling the annulus inwards, but you are pulling the leaflets away from the two papillary muscle heads and increasing the tethering or stretching that you would observe on the leaflets both in diastole and systole. So as you can see here, these arrows indicate the direction in which the annulus is being pulled inwards. So we are forcing the leaflets to coapt onto each other, but we are pulling them away from the two papillary muscle tips which are laterally away. So we wanted to test the hypothesis that if we use a approximating suture in potentially every patient who is getting functional mitral repair, first get the papillary muscles together and then put in an annuloplasty ring, you may have much better outcomes because we now have a much better force balance and relief of the tethering that you would see in the edge of the leaflets. So we tested that in the laboratory. We took adult pigs and induced functional mitral regurgitation using percutaneous techniques to induce functional MR. And after 8 to 10 weeks of inducing a posterior lateral infarction, we could actually see some moderate degree of regurgitation. It is quite tough to get severe mitral regurgitation in pigs.
This is with alcohol ablation of the circumflex, which is very much similar to this 15-year-old girl.
And after functional mitral regurgitation develops, we had randomized these pigs to 3 different groups. The first group is papillary muscle approximation only, as you can see here, where we are drawing the 2 papillary muscles together. Second is undersizing annuloplasty, and the third is a combination of both of them. So we did this similarly to the human setting, where we took the pigs on cardiopulmonary bypass, cardioplegic arrest, and then performed this and survived the animals to 3 months after the repair. We performed echocardiography at different levels, trying to understand the septal lateral dimensions, the tenting height and tenting area, and also the leaflet coaptation lengths. What we found was that in papillary muscle approximation only, this is the septal lateral annular diameter, we found that the annular diameter did not change immediately after the repair, which is expected because we did not do any repair at the annular level. Over time, there was a slight dilatation in the annulus, which is also expected because there is no reinforcement at the annular level. When we performed ring only, we saw that there was a reduction in the annular dimension, which is expected, and that it did not change over a period of time. And similar results were seen with papillary muscle approximation and the ring. However, when we look at tenting depth, we found that by approximating the 2 papillary muscles, we could significantly reduce the tenting depth or tethering you would see on these leaflets, and that sustained at 3 months after the repair as well. However, with ring, there was a significantly higher tenting depth, which corresponds to the tethering that I had previously mentioned, that the ring imposes on the leaflets. Whereas with the papillary muscle approximation with the ring, we found that the tenting depth was much less. So the improved tenting depth with papillary muscle approximation with or without a ring, the reason behind that is that enables better leaflet mobility. So to quantify that, we also looked at what is the tenting area between the annulus and the anterior leaflet only, and between the annulus and the posterior leaflet only. By breaking this down into 2 different tenting areas, we are able to establish which leaflet is actually has better mobility, pre-repair, post-repair, and at chronic outcomes. And what we observed was that after papillary muscle approximation, both the anterior and the posterior leaflet mobility was significantly improved, whether we put a ring or we do not put a ring. So based on these results, also the coaptation length was significantly higher when we used papillary muscle approximation. So obviously our initial hypothesis was we are reducing the tethering on the leaflet edges with papillary muscle approximation, so this should be done in every single patient. However, we did not directly measure that in this. So what we did was we used the 3D echocardiography images from these pigs to develop a computational model in which we can measure the caudal forces and the tethering imposed on the edges of the leaflets. And what we found, we performed the different repairs in this setup, and what we found was that papillary muscle approximation reduced the stresses and also the tethering forces that are imposed on the marginal chordae with or without a ring. So based on this data, which is the first part of my talk, what I recommend is that if functional mitral regurgitation repair has to be performed, it could be performed with the papillary muscle approximation and just a true size ring without too much undersizing that would pull the leaflets away from the 2 papillary muscle heads. So where are we going next with this part of our work is we have a NIH grant in revision which is trying to look at randomized comparisons of patients getting gesturing with ring versus papillary muscle approximation, and use images from these patients to actually perform detailed computational biomechanical modeling to define the mechanistic basis for why we propose papillary muscle approximation to be a better technique in this for surgical repair of FMR. Moving on to the other parts of my talk, the next step that we have taken is, yes, papillary muscle approximation is great, but it is quite challenging to perform using transcatheter techniques. As Dr. Guyton mentioned, if earlier repair has to be is advocated, transcatheter repair of FMR might be the procedure of choice. So instead of performing papillary muscle approximation, what we try to do is, if we had the ability to extend the edge of the leaflets, then we can permanently create a better leaflet shelf onto which coaptation of the anterior leaflet could occur. So the mechanism is pretty straightforward, as shown here. If we attach something to the edge of a leaflet, not clip the two leaflets together, you have a much thicker and a longer leaflet, and that would go into coaptation and eliminate regurgitation. So we developed a simple nitinol prototype in our laboratory, which attaches to the leaflet, or the native mitral valve leaflet, and when we tested it in a pulsatile flow simulator that we developed in our laboratory, this is pre-repair, where you can see the very nice functional MR gap between the two leaflets, and this is post-implantation of the device, where you can see that the entire regurgitation orifice is covered because the device is now attached to the edge of the leaflet, and we now have an enhanced leaflet edge.
The posterior leaflet is relatively larger in the pig, so it's attached to the posterior leaflet.
Yes. This is in a pig where we induced functional mitral regurgitation and then repeated the same echocardiography by implanting the device onto the posterior leaflet. And what we found in this are two interesting things. Firstly, we can eliminate regurgitation, but secondly, because we have enhanced the shelf of the leaflet, the anterior leaflets coapse onto this enhanced posterior leaflet much ahead in the mitral orifice. So you can see the nice bend, which is relief of tethering on the edges. So if you have future left ventricular remodeling, the ability to coapt earlier might compensate and reduce the recurrence of regurgitation. What happens within 90 days is the device that we have now attached to the leaflet becomes part of the leaflet because it is covered in EPTFE, and that permanently enhances the leaflet, so now you have a much enhanced leaflet coaptation. This work is currently in progress. We are trying to develop transcatheter versions of this to deploy onto the leaflet and show that you can completely eliminate regurgitation from commissure to commissure without the ability for, without creating any stenosis, as you potentially could see with the MitraClip. So the last part, which I will take a few minutes, is looking at functional mitral repair. We are developing new techniques, but is it any relevant? So earlier versus later versus never repairing functional mitral regurgitation is a controversy that continues. And in the laboratory, we wanted to understand, how does the left ventricular remodeling really differ when you have an ischemic ventricle with or without regurgitation, firstly? Secondly, how does a ventricle with functional mitral regurgitation differ in the remodeling pattern compared to primary mitral regurgitation, where you only have volume overload, but you do not have any ischemic cardiomyopathy of the ventricle? There are several clinical trials, as you all know, which are looking into this problem, but there are several issues with performing clinical studies in this type of patients. Firstly, FMR severity differs between patients. Also, the duration of FMR before they present to the clinic may be different between each one of them. So the history of left ventricular remodeling might differ. The infarct sizes, the transmurality, and the infarct viability is also significantly different between patients, and also the location of the LV remodeling on the spectrum of the remodeling at the time when they present for surgery or for echocardiography would be quite different. So we developed a high throughput rodent model of functional mitral regurgitation where we can control every single aspect that I had just presented to you. So this is a photograph with the rat in a right recumbency position with a left thoracotomy performed. We have intubated the animal, and we are using an 8 French ice catheter as our TEE probe. And in a beating heart, under direct image guidance, we are putting a needle directly through the apex of the heart into the mitral valve. So it creates a hole in the mitral valve and creates regurgitation. And now we can look at these rats with or without a myocardial infarction, or with a smaller versus a larger myocardial infarction, and look at how do they actually progress towards failure. So this is a video of the procedure of how we perform it. You can see here, you can see the beating heart. We place a purse string suture, then we advance the needle into the leaflet. This is the TE probe, and you can see the needle tip on the echocardiography right there. So
I can't believe these guys can do this. Beating what, 400 times a minute?
Yeah, there's 400 beats per minute. So we advance the needle into the mitral valve, and on color Doppler, you will be able to see the regurgitation. So you can see the regurgitation going through the mitral valve right there. So once we have confirmed this, what we do is we randomize the animals to 2 groups. The first group is regurgitation only.
You want to stay close to the mic so people can hear you remotely.
Sorry.
You're not really hearing half of you.
The first group is regurgitation only, and the second group is regurgitation with a myocardial infarction, where we induce the infarction by ligating the left coronary artery. Once we achieve this, we follow these animals to 20 weeks with every 2-week transesophageal echocardiogram and also a transthoracic echocardiogram to understand how the left ventricle progresses. And also at some time points, the 2-week, which is the early acute MR, 10-week, which is subchronic, and 20 weeks, which is chronic. We have also taken some rats to do invasive PV loops to actually get the ventricular performance. So this is the gross pathology at 20-week termination, where you can see that the rats without age and weight matched rats without any disease have a much smaller ventricle. Rats with just a myocardial infarction do have a larger ventricle, but it is not as large as that we see with regurgitation and an infarction, which you see here. And in the regurgitation only, you can see a much thicker ventricle that is dilated, whereas in the combination of infarction and regurgitation, which is representative of FMR patients, you not only see dilatation, but you actually see thinning of both the infarct region and the remote region as well, which is kind of expected because there is a low pressure volume overload on these ventricles throughout the entire process. So when we look at the ejection fraction, the black line is the sham. You do not see that it has changed over a 20-week period. Green is regurgitation only, where you can see that initially the pop-off effect of the valve enables better ejection fraction, but over a period of time it gradually starts to go down, but even at 20 weeks you do not see that much of a reduction in the ejection fraction. When we have a combination of MI plus MR or MI, which is the blue line here, we see that at 20 weeks their ultimate destiny is the same. However, the path slightly differs. When we look at the combination of MR and MI, initially there is a preservation of ejection fraction, but after the 6 to 8 week time point, we see a very gradual, very rapid fall in the ejection fraction. Whereas when you have an infarction only, we start to see that rapid fall very early on after the infarction period, and by the 10 weeks it starts to plateau. We looked at the end diastolic volume, and what we have seen is that irrespective of whether it's an ischemic or non-ischemic ventricle, MR dilates the ventricle and EDV continues to grow over time. And we have done some preliminary work which shows the potential structural proteins which are involved in the ventricle that are contributing to this. So you can see the red line and the green line here. The green is primary MR, which is MR only, and the red is MR with an infarction, which is equivalent to FMR. We see that at 20 weeks, both of them are significantly more dilated compared to an MI only or sham only. Similarly, when we measure the end systolic volume, we see that the combination of regurgitation and an infarction significantly elevates the end systolic volume, indicative of systolic contractile failure compared to just regurgitation or an infarction. So there definitely seems to be in this model a contribution of regurgitation towards rapid dilatation and failure in the setting of functional mitral regurgitation. When we look at the pressure volume loops at 2 weeks, 10 weeks, and 20 weeks, we see a gradual rightward shift of the combination group compared to the other, any of the other groups, which is the red one here. You see that it starts to move gradually to the right. So when we looked at the gene expression in this tissue, which will be one of my last slides, what we found was that when we had regurgitation only, we see a high upregulation of inflammatory genes and extracellular matrix degradation genes. When you have an infarction only, you actually see upregulation of fibrotic genes. But when you superimpose regurgitation onto the infarcted group, we start to see that most of the pro-fibrotic genes are suppressed and the extracellular matrix degrading genes and the inflammatory genes are highly upregulated. So what we concluded from this preliminary biological work is that when you have regurgitation in an ischemic ventricle, there could be a potential upper hand of regurgitation in the deleterious effect on the ventricle than just an MI only. So that is what we have seen so far, but we have to confirm this at the protein level and also try to relate this to the functional work that we have performed.
This is exploratory, just three in each group or so.
Yes.
So expensive.
So, and we are going to try different drugs in this to look at how does the timing of giving various different types of drugs and what are the different types of drugs and how can they actually impact without correcting regurgitation, the left ventricular remodeling process. So that is our current ongoing work in functional mitral regurgitation. There are no definitive answers yet, but we are definitely exploring and in the right direction. As you can see that papillary muzzle approximation is gaining popularity. An Italian group has just reported a 96 patient trial randomizing between papillary muzzle approximation and annuloplasty in JACC about 2 to 3 months ago. So with that, I'd like to end my part of the talk, acknowledge everyone, firstly Dr. Guyton for the opportunity and Dr. Taylor and all my collaborators within Division of Cardiac Surgery and my entire team and of course my funding agencies. Thank you.
That was great. That was fantastic and some really interesting animal models. I'll start with two questions. One, with the papillary muscle approximation, what happens to the ventricular geometry? Now, clearly, in the failing heart, you have a dysfunctional geometry, more globular, et cetera. So, does it change? It looks like in one of the echoes that Robert showed that there was sort of a change in overall geometry. Does that occur, and is it good or bad, I guess?
It really depends upon where you're approximating. If you're approximating the tips of the papillary muscles, you would see a much bigger impact on the valve without ventricle. But the way Dr. Guyton has done it is encircling them at the base. So when you pull them together, I'm guessing there will be a reduction in the LV EDD, which I'm hoping will have a beneficial effect.
When we encircle at the base, it's about a third the way down the ventricle toward the apex because we actually go into the wall around the belly of the papillary muscles and pull them together. This is similar to the coapsis device that with the spear that went through the heart that pulled the heart together, and this is about the same level as the coapsis device. And as we remember, the coapsis device was a victim of the 2008 stock market crash, and that device was taken out of development, even though the device appeared to have benefit in reducing function. So we are thinking that this pulling the bellies together is the intraventricular and perhaps transcatheter method of doing the coapsis device.
Okay. I just think it'd be interesting to look at the potential impact on the geometry because the geometry is pretty dysfunctional in these people. The second question was about the gene expression stuff. So that's the whole ventricle?
Yes.
Yeah, so the difference is when you have the combined and when you have the MI, how much of that is real changes in gene expression versus just heterogeneous populations because you have scar and periscar area and stuff like that?
So all of this work was from the remote region. So we exclude the scar, we exclude the border zone, and we go remotely. And we have to look at the remote region as well, but currently we try to mimic everything which is non-ischemic so that we can have a one-to-one comparison.
Other questions? Andy?
So a lot of your investigation focuses on the mitral regurgitation, but the mitral valve obviously plays a big role in the mechanics of left ventricular contraction, and the data that showed that post-MI that mitral regurgitation was associated with the worst outcome. How much of that do we think is due to increased volume for mitral regurgitation? How much is it regional dysfunction of the myocardium that might create abnormal wall forces in those regions? And how do we get at these types of things in these investigations? It's more than just what goes back to the left atrium, right? It's what's actually going on with the mechanics of that left ventricular contraction within the valve. And along that, if you could just comment on in this patient who had the valve replacement, what is done in that situation to try to preserve the mechanics of the myocardial function?
I'll answer the first question because I think the second question is better answered by Dr. Guyton. When it comes to the first question, you're right. We do not know the contribution of the MI versus the mitral valve. But if we firstly look at MI, which is one of our control groups, and the combination of MI with MR, we are not comparing MI with MR just to the sham. We are actually comparing it to the MI group with an equivalent size MI. So that distinguishes what is the impact of the regurgitation alone. But there could be other impact. There could be an impact of regurgitation on how the scar actually heals over time as well in this model, which is it could stretch more, it could become thinner quicker, and we still have to do those experiments where we can modulate the scar while keeping the regurgitation and look at if we modulate the scar from becoming thinner quicker or expanding quicker, can we stop the remodeling which we are currently attributing to the regurgitation? And we have not done that experiment yet, but that is something that we should be pursuing.
I think this is why at the beginning I said that this is maybe not the next frontier, but the next challenge, because it's so complicated, and you start and you end up getting your hands around more and more and more and more. And certainly when we do the papillary muscle approximation, we leave all the chordae attached except for but we do split the anterior leaflet so it spreads apart to allow the outflow tract to be wide open. But we don't, the answer is we don't know at this point. We don't know, and these are very pertinent and appropriate questions that have to be determined. I think it is nice that we've developed a large animal model and now have a smaller, less expensive small animal model that we can begin to address these questions.
I have a comment and a question. The comment is that your model of causing mitral regurgitation is interesting. We had a patient recently who had a very tortuous circumflex artery, and we were stenting it, and just putting a wire down straightened that posterior branch, and the patient got extremely sick with severe mitral regurgitation, and once we took the wire back out, it went away. So that's something we might experience as a problem in the cath lab. And then question is any model of hypertrophic cardiomyopathy, any animal model that you could study? We see these patients with another form of functional mitral regurgitation, you just do the hypertrophic obstructive phenomenon that goes away with alcohol ablation. So I wonder if there's any animal model you could use to study that.
Yeah, so thank you for your comment. The first, in relation to the comment, one of the reasons why you may be seeing FMR when you're occluding transiently the left circumflex is that there's a transient loss of the interpapillary muscle distance, because when you probably have transient ischemia, there's dyskinesis of that wall. The ventricle doesn't dilate, but the papillary muscles do not come closer to each other, which we have shown in 2014, published in JACC, that just that factor is sufficient to create regurgitation. So I think that is something we try to mimic in this model too.
So failure of the papillary muscles to move toward each other in systole leads to regurgitation. You don't even have to have spreading, it's just failure of systolic approximation of the papillary muscles. So if you get a little stunning of that part of the ventricle which pulls the papillary muscles together, you'll get MR.
And regarding hypertrophic obstructive cardiomyopathy, there are some models to do that, but they are not genetic. They are more mechanical, where we can inflate a balloon in the septum to create a bulge in the left ventricular outflow tract. And that can cause systolic anterior motion, and you do see some regurgitation. And this is work we have not performed in the laboratory, but others have shown and published it.
We're not even going to go there because he's spreading his arms around too much already. So.
Any remote questions? Well, with any other questions? Okay, well, with that, thanks both of you very much. That was fantastic.
The preceding program is copyrighted by Emory University.